Hello to all of you. Today we will be discussing anatomy questions for subject-wise series. We will be discussing today from question number 1 to question number 20. In the question number 1, the question is asked that which of the one is derived from all the three germ layers. In this the answer is A. The answer is A. The tympanic membrane is a structure which is derived from all the three germ layers. If we see in the ear we are having three portions. First is the external ear, then we have the middle ear and then the inner ear. When we see the external ear, the portions of the external ear, it is consisting of the ear pinna and it has the external aqueous meatus or the external aqueous canal. Now the ear pinna is derived from the first and second arches. The first and the second arch, it gives rise to 6 auricular hillocks which surround this external aqueous meatus and it gives rise to the ear pinna. So we use the term auricular hillocks. And these are 6 in number. These are 6 in number. Now for the external aqueous canal, it develops from the first cleft, the first ectodermal cleft. Then the next portion of the ear is the middle ear. Now the various portions for the middle ear, the tympanic cavity as well as the mastoid antrum and the eustachian tube, all these structures they are derived from the tubotympanic recess, which itself is derived from the dorsal portions of first and second pharyngeal pouch. So the tympanic cavity, along with that eustachian tube and the mastoid antrum, all these are in the continuity. The mastoid antrum, these three structures, these are derived from the first and the second pouch, the first and the second endodermal pouch. Then if we talk about the various muscles in this, we are having two muscles. The two muscles are the tensor tympani and the stapedius muscle. The tensor tympani muscle, it is derived from the first arch and the stapedius muscle, it is derived from the second arch. Now the rest of the components which are present in the middle ear, it consists of the ear ossicles, and when we talk about the ear ossicles, we know that we are having three ear ossicles in which malleus, incus and stapes is there. The malleus and incus, it develops from the first arch, and the stapes, it develops from the second arch. The stapes, it develops from the second arch. Apart from that, the stapes is also developing from the one more structure, that is the otic capsule. The otic capsule, it is giving rise to the footplate of the stapes. So therefore the stapes is having a dual origin. It is arising from the second arch as well as it is arising, the footplate is specifically arising from the otic capsule. The footplate, it actually arises from both, but mainly it is arising from the otic capsule. The central portion is derived from this otic capsule and the peripheral portion, that is outside, it is derived from the second arch. So these are the structures of the middle ear which are derived from the various components. Now when we talk about the inner ear, the inner ear, it is derived from the otic vesicle. The inner ear is derived from the otic vesicle, which is actually derived from the otic placode, which is a surface ectoderm. Now this otic vesicle, it divides into two portions, the ventral portion and the dorsal portion. The ventral portion, it gives rise to the semicircular canal, and it gives rise to the endolymphatic sac and the endolymphatic duct, as well as it is giving rise to the saccule. And then the dorsal portion, it gives rise to the cochlea and the utricle portion. So therefore the whole bony labyrinth, the whole membranous labyrinth, it is arising from the otic vesicle. So these are the structures. If we visualize for the whole of the ear is derived in such manner from the various components. In this, for the middle ear, the tympanic membrane is there towards the lateral side of the middle ear. And this tympanic membrane, it is derived from all the three germ layers. Now if you see this picture is showing us the endodermal pouches. We know regarding the pharyngeal apparatus, the pharyngeal apparatus is having three components: pharyngeal arch, then pharyngeal cleft, and the pharyngeal pouch. The pouches are endodermal in nature, the arch is mesodermal in nature, as well as it is having migration of the neural crest cells. Then on the outer aspect, the pharyngeal clefts, they are ectodermal in nature. So over here we can see this picture is showing the endodermal pouch, and in this, the first and the second endodermal pouch, their dorsal portions, the dorsal part of this, they form the tubotympanic recess, which is giving rise to auditory tube, as well as it is giving rise to the middle ear cavity, that is the tympanic cavity, and the mastoid antrum. From the outside, this portion is the cleft portion. This is the first ectodermal cleft, and it is giving rise to the external auditory meatus and the canal. In between this portion over here, this is a portion which is forming the tympanic membrane. So if we see over here in this portion where it is forming the tympanic membrane, we can see in this portion there is presence of ectoderm, there is presence of endoderm, as well as in between there is some portion of mesoderm. So therefore this area, that is a tympanic membrane, will be giving rise or will be arising from all the three germ layers. Now this picture is showing the development of the external pinna. As we have just discussed, for the external pinna or the ear pinna, it develops from the 6 auricular arches. Over here we can see there are 6 auricular arches and auricular helix, which are derived from first and the second pharyngeal arch. If we see these auricular helix, in this first 3, they are derived from the first arch, and the next 3, they are derived from the second arch. And they are surrounding the external equistic meatus. Later on they will lead to the formation of various portions of the ear. And when we talk about the various portions of the ear, if this is the ear, towards the medial side of the ear we are having the tragus. This is the tragus. And towards the outer side we are having this helix. This is the helix portion. This is a crus of helix. This portion over here, this is the antitragus. Then just below this, over here we are having antihelix. This is the antihelix. These are the various portions of the ear pinna. Now in this, when we talk about the 6 auricular helix, the first auricular helix, it gives rise to the tragus. The second auricular helix, it gives rise to the crus of the helix. The third one, it gives rise to the helix portion. Then as we come towards this lower side, the fourth is giving rise to this antihelix. Then over here, fifth is antitragus, and the last one is giving rise to this ear lobule. So therefore we can see that the 6 auricular helix, they are giving rise to the different portions of the ear pinna. Now this diagram is showing the formation of the tympanic membrane over here. We can see the tympanic membrane. The same thing is over here. over here we have seen that this is the tympanic membrane which is formed from this side toward tympanic recess, and towards this side the first cleft is there. And the bones which are formed over here, the three ossicles, they are formed by the mesenchymal condensation which is present over here. Apart from this, we can see the formation of otic vesicle. This portion which is present over here, this is the otic vesicle. This otic vesicle, it is formed from this surface ectoderm. This is a surface ectoderm over here, and it specializes to form the otic placode, and this placode, when it comes towards the inside and it is pinched off from the surface ectoderm, then we say the otic vesicle is formed, which will be giving rise to the inner ear. Now in the next question we have this diagram which is showing the deep cerebellar nuclei. If we see the picture over here, these are the two cerebral hemispheres, and in between this green portion which has been shown is the vermis. The nucleus which has been shown over here, this is the fastigial nucleus. Then after this, B is the globose, C is the emboliform, and the D1 is the dentate. These are the four deep cerebellar nuclei which are present in the cerebellum, and if we see from lateral to medial side, the lateral most is the dentate, then emboliform is there, globose, and the fastigial. The shape of the dentate is a crumpled bag shaped appearance. It is having a shape like this, which is similar to the nucleus of inferior olivary, the inferior olivary nucleus. Now when we talk about the portions or the parts of the cerebellum, if we talk about the phylogenetic division or the morphological division, it is being divided into three portions. First is the archicerebellum. Then second is the paleocerebellum. And the third one is the neocerebellum. Now in this, if we talk about this, these are the three morphological divisions of the cerebellum. The oldest one is the archicerebellum, which is having connections with the vestibular nucleus. Then neocerebellum is the newest one, and paleocerebellum is in between. The nucleus which are related to archicerebellum and the rest of the portions, if we talk about the nucleus which are related to this, for the archicerebellum, the fastigial nucleus is related to this. Then the paleocerebellum, to it, the globose and the emboliform nucleus are related to it, and they together they are known as nucleus interpositus. Neocerebellum, the dentate nucleus is related to this. Means this portion of the cerebellum is going to send fibers to the dentate nucleus. So the nucleus interpositus for this, which will be including the globose and the emboliform, and for the neocerebellum we have the dentate nucleus. So these are the various nucleus which are associated with these portions of the cerebellum. And if we talk about the components of these cerebellum, that which portions of cerebellum are included in this, the archicerebellum, it is including for the archicerebellum, it includes the flocculonodular lobe, as well as it includes the lingula. For the paleocerebellum, the portions which are included in this are anterior lobe, except the lingula, plus it also includes the pyramid and uvula. The neocerebellum, the newest one, it includes the posterior lobe except the pyramid and uvula. So these are the various components of the cerebellum and the nucleus which are associated with that, and the portions of the cerebellum which are included in this. If you talk about the archicerebellum, this is mainly for the maintenance of equilibrium. The paleocerebellum, it controls the crude movements of the limbs. The newest one, the neocerebellum, it is associated with smooth functioning or the smoothing of the highly skilled movements which are of precision movements. So it is for the smooth movement of those movements. So if you come back to the question in this, the question says we have to choose the incorrect option. That which is incorrect? A is the nucleus of paleocerebellum. So we know A is fastigial. So therefore it is a nucleus of the paleocerebellum. B is fastigial. This is also correct. Sorry, this is not correct. B is globose. C is included in nucleus interpositus. Yes, it is included. And D, dentate nucleus, it is shaped like inferior olivary nucleus. That is the crumpled bag appearance is there. So the answer for this question is B. This picture is showing the various portions of the cerebellum. It is divided into all these portions, and we have just discussed that which portion is included in which division of the cerebellum. Now the next question, it is regarding the Meckel's diverticulum. In this we know that the Meckel's diverticulum, it is due to the persistent of the proximal part of vitreointestinal duct. If we talk about the vitreointestinal duct, it is present in the embryo, and when it is present, this duct is actually going outside through the umbilicus, and it communicates outside with the yolk sac. So if this is the midgut portion, and this portion, this is the umbilicus, this is the yolk sac on the outer aspect. So in this case, now this is the vitreointestinal duct. The vitreointestinal duct, it is also known as Vitelline duct or the yolk stalk. Now this duct, if the proximal part, that means this much portion over here, if this proximal part, it remains patent, then it leads to a congenital anomaly, which is the Meckel's diverticulum, which has been mentioned over here. When this Meckel's diverticulum will be present, if this is the intestine over here, so as we have said that this portion, proximal part, is patent, so it will lead to such kind of projection, and it will be connected by the umbilicus by a fibrous band. This fibrous band may be or may not be present. So this is a fibrous band which extends from the apex of this Meckel's diverticulum till the umbilicus. This is the Meckel's diverticulum. Now if we talk about the Meckel's diverticulum, the Meckel's diverticulum, it is consisting of all the three layers of the GIT, the three layers, that is the mucosa, submucosa and the muscular layer. So therefore we consider it as the true diverticulum. So it is having all the three layers. All the three layers are present in this, so therefore we term it as true diverticulum. Then it is present at the anti-mesenteric border of the intestine. So it is present at anti-mesenteric border. More common in males, and there is a rule of 2. The rule of 2 says that it is present in 2% of population. Then it is 2 inches from the ileocecal junction. 2 feet from the ileocecal junction. Then the length can be 2 inch. So this is a rule of 2. Apart from this, at the point where the Meckel's diverticulum is present, there may be ectopic gastric tissue or the pancreatic tissue, and at this point, if the inflammation is there, it may mimic the acute appendicitis. And as well as if there is inflammation over here which will lead to diverticulosis, it will present as pain around umbilicus. Apart from this, if the fibrous band is present, as we have shown over here, then in this case there can be obstruction or volvulus may occur in this. So this a complication can occur, that is the obstruction, if the Meckel's diverticulum is present. So it may show in the form of various symptoms also, as we have just mentioned. Now if we come back to the question says, what is true regarding the Meckel's diverticulum? It is present in the mesenteric border, as we have said, it is present in the anti-mesenteric border. Then all the 3 gut wall layers are present. Yes, this is true. It presents commonly with lower abdominal pain. It presents as pain around the umbilicus. Then D says it is second commonest congenital anomaly. It is the first common or the most common congenital anomaly. So for this, the answer for this question will be B, which is true, that it is having all the 3 layers of the gut. The next question says the floor of the third ventricle is formed by all except, the answer for this question is D, that is anterior pituitary. The rest of the all 3 structures, they are forming the floor of the third ventricle. Now in this we know regarding the ventricular system, we are having 2 lateral ventricles which are present within the cerebral hemispheres. Then we have third ventricle which is present between the 2 diencephalon, or we say between the thalamus. Then the fourth ventricle is there. The fourth ventricle is present between the pons and the cerebellum. The intercommunications between the lateral and the third ventricle is via the foramen of Monro or the interventricular foramen. Then third ventricle, it continues as cerebral aqueduct, and this cerebral aqueduct is continuing into the fourth ventricle. And this fourth ventricle, below it continues as central canal, shown over here, and the CSF from here majorly is going to the subarachnoid space, which is present at the roof of the fourth ventricle, and they pass through the foramen of Mesentery and the foramen of Lashka. Now when we talk about this third ventricle, if you see a section, a sagittal section for the third ventricle, this is a sagittal section which is showing the whole of the third ventricle. This is the third ventricle. Now in this, if we see what are the structures which are present or which are forming the floor, as well as roof and the anterior and the posterior wall, if we see the structures which are forming the floor. First of all, we will talk about the floor. Now starting from the anterior to the posterior aspect, the first structure which is forming the floor over here is the optic chiasma. Then just behind the optic chiasma we have this infundibulum of the pituitary gland, and this is the point where the tuberous cinereum is present. Then as we go more posteriorly, mammillary body is there, then posterior perforated substance and the tegmentum of the midbrain. So these are the structures which are forming the floor of the third ventricle. The third ventricle, if we see over here, this third ventricle is complete. This whole is the third ventricle from anterior to posterior side. So for the floor, the structures which are forming the floor, starting from anterior, the optic chiasma, then infundibulum, mammillary body, posterior perforated substance and the tegmentum of the midbrain. At the point of the infundibulum, we are having tuberous cinereum, which is for the passage of the pituitary stalk. So in this we can see the floor is formed by the infundibulum or the tuberous cinereum, and it is not formed by this pituitary gland which is present a bit lower down. So these are the structures which are forming the floor. Now if we talk about the roof, The roof is formed by the ependyma, which is extending from the between the two thalamus. Then we have the anterior wall. The anterior wall, it is formed by three structures. If we see over here towards this side, this structure is a column of the fornix, which is present over here. Then as we come lower down, anterior commissure and the lamina terminalis. These three structures, these are forming the anterior wall. So the anterior wall is formed from A to C. Then if we come towards the posterior wall, the posterior wall, it is formed by, towards the most posterior side we are having the lowermost part of the corpus callosum, that is the splenium. Then we have habenular commissure, pineal gland is there, posterior commissure, and this posterior commissure, it is commencing to the aqueduct of Sylvius. So these structures, these are forming the posterior wall. These are forming the posterior wall, and along with that we are having the lowermost portion of the corpus callosum also, that is the splenium. Now if we talk about the lateral side or the lateral boundary, the lateral wall, this lateral wall is formed by the thalamus and the hypothalamus. The upper, or we can say the major portion is formed by the thalamus, and the some portion contributed by the hypothalamus. If you see in this picture, there is a hypothalamic sulcus. This sulcus, which is extending from interventricular foramen to the beginning of the aqueduct. This is a hypothalamic sulcus, which divides this whole portion into upper larger portion and the lower smaller portion. The upper larger portion over here, it is formed by anterior 2/3 of the thalamus, and the lower portion is formed by hypothalamus. So therefore these are the two structures which are forming the lateral wall. So the answer for this question is anterior pituitary, that is a D, and the rest of the structures, they are forming the floor. For the next question, you have to identify the muscle which causes protrusion of the mandible. Now in this, if you see all the muscles in the picture, this A over here, we can see, first of all we have to identify the parts of the mandible. This portion over here, this is the coronoid, process of the mandible, and the muscle which is attached to the coronoid process is the temporalis muscle. This process over here, this is the condylar process, and the muscle B over here which has been shown, this muscle is actually attached to the condylar process, and this muscle is inserting into a depression which is just present anterior to this condylar process, and that depression is known as pterygoid fovea. The muscle which is attached over here is the lateral pterygoid. The lateral pterygoid muscle attached on pterygoid fovea. Now the rest of the muscles, if you see C and D, these muscles, they are attached near this angle of the mandible. If you see towards the angle, this C muscle is towards the inner aspect, or we say towards the inner aspect of the mandible. The muscle which will be attached over here, this muscle is the medial pterygoid muscle. On the outermost side, D, this is the masseter muscle. So if you see, this picture is actually showing the attachment of all the muscles of mastication, the 4 muscles of mastication. Now in this we have to decide that which is the muscle which is actually helping in the protrusion of the mandible. If we talk about the actions of all the muscles, for the protrusion of the mandible, the lateral pterygoid is the one which is the main muscle which acts for the protrusion of the mandible. It helps in the protrusion of the mandible as well as it moves the mandible down. So the answer for this question will be lateral pterygoid, which is the option B. So the answer for 5th question is B. If we talk about the protrusion of the mandible, all these movements, these are by the muscles of the mastication and they are acting on the temporomandibular joint. In this, mainly it is by the lateral pterygoid and it is assisted by the medial pterygoid also. The medial pterygoid also. Then we have retraction. The retraction of the mandible is by the temporalis muscle. Then for the depression of mandible, the depression of the mandible, when the mandible goes down, it helps in the opening of the mouth, and this is by the lateral pterygoid. The elevation of the mandible, in the elevation of the mandible, there will be the closure of the mouth or the oral cavity. The elevation is mainly by temporalis as well as masseter and medial pterygoid. So these are the muscles which are causing the various movements at the temporomandibular joint, and in this the lateral pterygoid is the one which is helping in the protrusion of the mandible. So the answer is lateral pterygoid. Now next question is regarding the Bartholin gland. In this we have to tell except, which option is not correct. When we talk about the Bartholin gland, it is actually present in the females, and this gland is present in the superficial perineal pouch. The Bartholin gland which is present over here, it is homologous with the bulbourethral glands of the male, the bulbourethral gland of the copper, which are present in the males. Now the location of this Bartholin gland, it is present at the junction of middle 1/3 and the posterior 1/3 of the labia majora. So if we see, these are the three portions: anterior 1/3, middle 1/3 and the posterior 1/3. The Bartholin gland which is present over here, it is present at the junction of middle 1/3 and the posterior 1/3. So when we talk about the Bartholin gland, also known as the greater vestibular gland, first of all, they are homologous with the bulbourethral gland, and they are present at the junction of the middle and the posterior 1/3. Now the duct of the Bartholin gland, it is longer and it is opening into the vestibule, and it is opening between the hymen and the labia majora. Now if you see this picture, this is a section, the coronal section through this perineal area, which is showing the vagina above and the lower portions below. Now the vagina which is present like this, towards the lower side it is having hymen, then there are two structures which are present over here, the labia minora and the labia majora. This is the labia minora and this one bigger fold is the labia majora. There is a presence of perineal membrane over here. The perineal membrane is present over here. Now the space which is present superficial to the perineal membrane, if we consider that as the superficial perineal pouch, and the space which is present deeper to it is the deep perineal pouch. Now this Bartholin gland, it is present in the superficial perineal pouch. This is the superficial perineal pouch. And the duct is going forwards and it is opening over here. The opening of the duct, if we see, it is between the hymen and the labia minora. This is the point where it is opening. Now how it is different from the bulbourethral gland in the males? In the bulbourethral glands, they are present in the deep perineal pouch in the males, and their ducts are longer. The ducts, they open towards the superficial perineal pouch. This is the Bartholin gland. Now if you go back to the question says we have to find the exact option. It is homologous. A option is correct. It is present in the superficial pouch. In this the C option is not correct and the D is also correct. So the answer for this question is C, because the location is different as we have discussed. The next question, the question number 7, it is regarding the elbow joint. In this, first of all, we will identify the A and B which are written over here. The A which is written over here, this is the annular ligament. The B over here is the ulnar collateral ligament, and to be specific, this is the anterior band of ulnar collateral ligament. Now when we see the elbow joint, regarding the elbow joint, it is formed by the humerus, the lower end of the humerus. If you see the lower end of the humerus towards the anterior side, it is having projections over here which are termed as capitulum and the trochlea. The capitulum, it is a round structure. A round structure which is present like this is the capitulum, and a dumbbell shaped structure which is present over here is the dumbbell shaped structure which is present over here, this is the trochlea. So this is the capitulum and this structure is the trochlea. Then on either sides we are having the condyles, the tips of which are termed as the epicondyles. Now just near the capitulum there is a depression over here, a depression is there, and this depression is known as radial fossa. And a depression which is just adjacent to trochlea is known as coronoid fossa. Near the capitulum, this portion is articulating with the radius bone is there. The head of the radius is articulating with the capitulum, and the coronoid process over here, the coronoid process of the ulna, this is the ulna. The trochlear notch, or we say towards the coronoid process, it is articulating with the trochlear portion. When the flexion occurs at the elbow, the coronoid process which is present over here towards the anterior side, it goes into the coronoid fossa, and the head of the radius, it goes towards the radial fossa. Now this is when we view from the anterior side. If you view from the posterior side towards the posterior side, this is the posterior view. Now over here again a depression is present in the lower end of the humerus, and this depression is known as olecranon fossa. This olecranon fossa, the olecranon process, it lodges in it during the extension of the elbow joint. And when we see this elbow joint from the lateral side, for the lateral view, this is the humerus, and we have the ulna over here towards the lower side. The ulna sends a projection towards the upper side, which is the olecranon process. Now this is the olecranon process, and this is the coronoid process towards the anterior side. The notch, the U-shaped notch which is extending from anterior to posterior, this is the trochlear notch. Now the capsule of the elbow joint, when we talk about the capsule of the elbow joint, it is attached in such a way, when we see its attachment in the humerus, it is attached in such a way that it includes all these components, that is, it includes the capitulum, trochlea, as well as it includes the radial fossa and the coronoid fossa. This is the capsule. And towards the lower side, in the ulna, it is attached to the margins of the trochlear notch, so over here, and as it goes towards the radius, it merges with the annular ligament. So as it is merging over here with the annular ligament, it is present around the head of the radius. So when it is merging over here, the cavity, the synovial cavity of this elbow joint, it is continuous with the synovial cavity of superior radioulnar joint, which is being formed over here. So this is how the capsule is attached. The rest of the ligaments which are present over here, if we talk about the ligaments of elbow joint, one is the capsule, then the anteriormost portion of the capsule that thickens to form anterior ligament, and the posterior portion, it thickens to form the posterior ligament. The anterior ligament and posterior ligament. Apart from this, we are having ulnar collateral ligament and the radial collateral ligament. For the ulnar collateral ligament, it is a triangular shaped ligament, and if we see from the lateral side, this is a lateral view, humerus over here and ulna over here. The ligament, it extends from the epicondyle which is present over here, that is the medial epicondyle. It is having anterior band and a posterior band. The anterior band, it extends from the medial epicondyle, this is the medial epicondyle, and it goes till the coronoid process. The posterior band, it begins from the medial epicondyle and it goes towards the olecranon process. So this is the anterior band and this is the posterior band of the ulnar collateral ligament. Among this, the anterior band is the one which is the most strong. Now there are few fibers which the fibers which are running obliquely, and they connect the anterior and the posterior band. So this completely is forming the ulnar collateral ligament. For the radial collateral ligament, it is present towards the radial side. If this is the humerus and below we are having the radius, this ligament, the radial collateral ligament, it again begins from the lateral epicondyle and it goes below and it is going towards the whole of this head. It goes below and it merges with the annular ligament of the radius. So this is a fan shaped ligament which is present over here. The starting point from here is the lateral epicondyle. So these are the major ligaments in the elbow. Now if we come back to the question says we have to mark the incorrect statement. The incorrect statement, first option is the synovial lining of elbow joint, it extends inferiorly deep to A, that is deep to annular ligament, and it is continuous, it will be continuous with the synovial cavity of superior radioulnar joint. So this is correct. Now this B option, this is wrong, because radial fossa as well as olecranon fossa as well as the coronoid fossa, they will be intracapsular. In this we have studied that this is the attachment of capsule on the anterior side. If we see the attachment of capsule on the posterior aspect, it is along the margin of this olecranon fossa. So it is including olecranon fossa also. Then B, the C option says B is the strongest band of ulnar collateral ligament. This is correct. The brachioradialis is a muscle which is effective flexor in mid-prone position. This is also correct. So the answer for this question 7 will be B. Now we come to the next question. The question number 8, it says that the nerve supply of the submandibular gland. The answer for this question is B, that is, it is supplied by the lingual nerve. Now the nerve supply of the submandibular gland is via the submandibular ganglion. As we can see in this picture, the submandibular gland, it is present over here. This is a submandibular gland and it is being supplied by a ganglion which is present over here. This is the submandibular ganglion over here. And if we see this ganglion, topographically it is related to the lingual nerve and functionally it is related to the facial nerve. This is the lingual nerve which is coming from here, and we can see that this lingual nerve is sending roots which gives attachment to this submandibular ganglion. So topographically this ganglion is related to this lingual nerve, And functionally we can see that the fibers, they are coming from this pons area. The fibers are coming from the pons and they are traveling through the facial nerve. So functionally it is related to the facial nerve. Now this ganglion is carrying the parasympathetic fibers, sympathetic fibers and the sensory fibers, and they are given off to the submandibular gland for its supply. The parasympathetic fibers, they carry the secretomotor fibers to the submandibular gland, which is responsible for the secretion of the saliva. The sympathetic fibers, they are vasomotor in function, and more they are having vasoconstrictor action, due to which the blood supply is decreased and the saliva secretion, it becomes more thick. Then the sensory supply is through the lingual nerve. When we talk about these supply, for the parasympathetic supply, the parasympathetic supply, it begins in the pons and it is beginning by the superior salivatory nucleus. From here it passes through the sensory root of the facial nerve, which is the nervus intermedius. Then through the facial nerve, it passes through one of the branch of the facial nerve, that is the cauda tympani nerve. Now this cauda tympani nerve, it is having connections with the lingual nerve. So the fibers now travel in the lingual nerve, and now via the lingual nerve we can see the fibers which are coming from this point. We see in this picture, it is coming like this, it travels through the cauda tympani, and now it is having connections with the lingual nerve. Now through the lingual nerve, now it will reach to the ganglion. Over here it will relay, and the fibers which arise from here will now reach towards the submandibular gland. Therefore supplying the secretomotor supply is being given to this gland. For the sympathetic supply, if we see over here, this is a sympathetic supply. This sympathetic supply is through the sympathetic plexus, which is formed around the facial artery, and these fibers, these are coming from the superior cervical ganglion. The sensory supply, it is also through the lingual nerve. So the answer for this question is the lingual nerve, which is for the submandibular gland. This next question, it is talking about the external hemorrhoids. Now when we talk about the hemorrhoids, in the hemorrhoids which are present above the pectinate line, they are termed as internal hemorrhoids, and the one which are present below the pectinate line, those are the external hemorrhoids. Now as we can see in this picture, this point over here, this is the point of pectinate line. The hemorrhoids which are present above this, these are internal, the internal hemorrhoids, and the one which are present below it, those are the external hemorrhoids. Now the structures or the portion of the anal canal which is above the pectinate line, it is having different nerve supply, different arterial venous supply, as well as the lymphatic supply is different. If we see the difference in this picture is showing the difference in this. This is the point where the pectinate line is present, and if you see the nerve supply, the portion of the anal canal which is above the pectinate line, it is supplied by the autonomic nerves. It is having sympathetic as well as parasympathetic supply. The parasympathetic, it is coming from S2, S3 and S4, and the sympathetic is coming from L1, L2. Below this region, it is supplied by the somatic nerve, the somatic motor nerve, and that nerve is the inferior rectal nerve. The inferior rectal nerve in turn is a branch of the pudendal nerve. Now if the hemorrhoids, they are present above this pectinate line, because they are supplied by the autonomic nerves, those hemorrhoids will be painless, that is internal hemorrhoids will be painless, and such kind of hemorrhoids, they bleed when there is when we strain during defecation. For the external hemorrhoids which are present below the pectinate line, they are supplied by inferior rectal nerve, which is a branch of pudendal nerve. So they will be painful because these are supplied by these somatic nerves, and they do not bleed on defecation. Now if we talk about the rest of the structures, the arterial supply for the upper portion is by the superior rectal artery. Below pectinate line it is supplied by inferior rectal artery. For venous supply, above pectinate line drains into the superior rectal vein, and below that, below pectinate line drains into the inferior rectal vein. If we talk about the lymphatic drainage, the upper portion it drains into the internal iliac lymph nodes, and below pectinate line it drains into the superficial inguinal lymph nodes. So in this way this whole portion is different. Now for the internal hemorrhoids, we divide it into primary piles and the secondary piles. For the primary piles, there are three positions which are specific for the primary piles, which are 3 o'clock position, then we have 7 o'clock position and 11 o'clock position. Any piles which is present at these positions, they are termed as primary piles, and if the location is other than these positions, then we consider them in the secondary piles. The internal hemorrhoids, these are due to the saccular dilatations of the superior rectal vein. And the external hemorrhoids, these are the saccular dilatations of the inferior rectal vein. If we see the venous plexus, we can see in this picture the venous plexus is there, which is formed over here. We are having two venous plexus. One is the internal venous plexus. This internal venous plexus, it is mainly formed by the superior rectal vein, and it is present just beneath the mucosa. Then we have an external venous plexus. The external venous plexus, it is present outside the muscular coat of the rectum, and it is contributed by all the three veins, that is superior rectal vein, middle rectal vein and the inferior rectal vein. The upper 1/3 of external venous plexus is contributed by superior rectal vein. The middle portion is contributed or drained into the middle rectal vein, and the inferior one is drained into the inferior rectal vein. The answer for this question is external hemorrhoids. These are painful because of the nerve supply from the pudendal nerve. So the answer is the pudendal nerve, that is the B option. Now for this next question, we have to identify the given slide. This is typically a slide of the gallbladder. For the slide of the gallbladder, if you see over here, the epithelium which is present over here, this epithelium is a typical columnar epithelium. In the columnar epithelium, if you see the columnar epithelium, we are having tall cells like this, and the nucleus is oval shaped, which is present towards the base. So the apical portion, it appears to be clear. So when we talk about the gallbladder, for the epithelium, it is columnar epithelium, and in this the cells, each cell is having the brush border. The columnar epithelium with brush border is there. That means towards the apical portion it is thrown into the microvilli so as to increase the surface area of absorption, and this type of epithelium is typically present in the gallbladder. Now when we see the mucosa portion of the gallbladder, the mucosa, we know that it is divided into three components. It is having epithelium, lamina propria and muscularis mucosa. We have already talked about the epithelium which is present over here, columnar epithelium, and this epithelium or the mucosa over here, the mucosa is thrown into folds like this, which we can visualize in this picture. So these folds, these are the temporary folds. Then just beneath the epithelium we have lamina propria. Lamina propria is a loose connective tissue layer which is having lot of lymphocytes. So when we see the picture over here, just below the epithelium, the layer which is present over here, we can visualize the dark purple nucleus, and these are the nucleus for the lymphocytes. which is present over here. The muscularis mucosa, it is absent in the gallbladder. Then the next layer of the GIT is submucosa. The submucosa also is absent in the gallbladder. This is also absent. Then we have the muscular layer. The fibromuscular layer which is present over here, it is having less number of the muscle fibers and less number of collagen fibers are there. So a thin layer is there. And after that, the layer which is present is the adventitial layer or the serosa layer. The serosa layer, it is present towards the inferior aspect, and the rest of the gallbladder is covered by the adventitial. So in this we can see that the muscularis mucosa, it is absent, the submucosa is absent, and the specific epithelium which is present is columnar epithelium with the brush border. These are the characteristic features of the gallbladder, and this slide is for the gallbladder. Question number 11, it talks about the mesentery. Now when we talk about the mesentery in the embryo, the gut portion, it is suspended by two mesenteries or mesogastrium. The one which is present towards the anterior side or the ventral side is termed as ventral mesogastrium or mesentery. Towards the dorsal side or posterior side, we have the dorsal mesogastrium. Now over here we can see this whole portion which is anterior to the developing gut. This is the ventral mesogastrium. This portion over here, this is ventral mesogastrium. And if we see, it is present only in the upper portions. The mesentery which is posterior to it, this whole mesentery, this is the dorsal mesogastrium. This dorsal mesogastrium, if we see, it is extending throughout this gut portion. Now what are the structures which are derived from the ventral and the dorsal mesogastrium? In this, if we see the adult structures which are formed, now in the ventral mesogastrium, as the liver is developing, the ligaments which are derived from this are, first of all, it gives rise to falciform ligament, the coronary and triangular ligament, and the lesser omentum. Now because the lesser omentum is extending from the liver to the stomach, it is also known as hepatogastric ligament. It is known as the hepatogastric ligament. The falciform ligament, it is formed by the anteriormost or the ventral part of the ventral mesogastrium. The lesser omentum, it is formed by the dorsal portion of the ventral mesogastrium. Now for the derivatives of dorsal mesogastrium, the dorsal mesogastrium, it gives rise to the greater omentum. Apart from it, the ligaments which extend from the stomach to the spleen and then from spleen to the kidney, we have gastrosplenic ligament, as well as gastrophrenic ligament, then splenodenal or the linodenal ligament is there. Apart from this, it is also giving rise to mesentery of the small intestine as well as the mesocolon. So these are the structures which are derived from the ventral and the dorsal mesogastrium. And if we see in this, the structure which is derived from ventral part of ventral mesentery, that is the falciform ligament, as we have discussed. So the answer for this question is the falciform ligament. Now the next question, it says that which of the structure is not associated with the vitellointestinal duct. When we talk about the vitellointestinal duct, as we have already discussed regarding this, the vitellointestinal duct, if this is the umbilicus portion and this is the gut portion, it goes towards the yolk sac, and it is a duct which is in communication with the yolk sac over here. Now this portion is present in the embryo, and by the 6th week of intrauterine life, around that week, it will start obliterating, and this structure, vitreointestinal duct, it is not present in the adults. If some portion remains patent, it may lead to the formation of various structures or various congenital anomalies. Now in this, if we see, if the whole portion of the vitreointestinal duct is patent, it will lead to a condition known as fistula. This is the fistula. And if this is present, the fecal matter will come out of this through the umbilicus. This is the umbilicus. So we term it as fecal fistula. In this, the whole portion is patent. If only the proximal portion is patent, that leads to the formation of Meckel's diverticulum. So if we draw again this picture, this is umbilicus, this is the gut, only the proximal portion is patent. It is termed as Meckel's diverticulum. And there may be a presence of fibrous band which extends from the apex of this diverticulum till the umbilicus. Now there may be a condition when the middle portion of this duct is patent. That is, a fibrous band is present over here. In the middle we have a patent portion is there. This is termed as enterocystoma. It is termed as enterocystoma, in which a small cyst is there, and anterior to that and posterior to that we are having the fibrous bands, or the duct is obliterated. Only this portion is patent. Then if the distal portion of the duct is patent, so it will be conditioned like this. Now in this condition, the duct is patent on the distal portion, and it is termed as umbilical sinus. A depression of the pit is present near the umbilicus. Now if we come back to the question says, which of the following structure is not associated with the vitreointestinal duct? In this, the diverticulum may be there, the sinus may be there, as well as the enterocystoma may be there. Now the mesenteric cyst, it is actually one of the tumors which is present over here, and it is not associated with the vitreointestinal duct. So the answer over here is D, that is the mesenteric cyst. Now if we come to the next question, which vertebral segment is numerically most constant? In this, the various vertebrae which are present in the vertebral column, they may vary in number, but the number of the vertebrae will remain same. And if we see, the one which is most constant is the cervical vertebra. So the answer for this question is A, that is the cervical vertebra. The next question, it says that we have to differentiate between the cervical and the thoracic vertebra. What are the points we will use to differentiate it? If we compare the cervical and the thoracic vertebra, the pictures, if you see, this picture is for the cervical vertebra, and this picture is for the thoracic vertebra. If we see both pictures, first of all, the body is different. The body of the cervical vertebra, it is smaller, and the body of the thoracic vertebra, it is in comparison to cervical, it is larger. And for the lumbar vertebra, they are having the largest body. If we compare this vertebral foramen over here, the vertebral foramen which is present over here, also termed as vertebral canal, it is having a triangular shape in the cervical vertebra, and in the thoracic vertebra either they are round or oval. And the vertebral canal over here, this is the vertebral canal. Now if we compare the spinous process, this is the spinous process on the posterior side. The spinous process of cervical vertebra, they are mostly bifid like this, they are having this way. And in the spinous process, in the thoracic vertebra, they are not bifid, and they are pointed, and they are long. The spinous process are long. If we compare it with the spinous process of the lumbar vertebra, in the lumbar vertebra, the spinous process, they are not bifid, but they are smaller and they are more thicker. Now one of the main characteristic present in the cervical vertebra is the presence of foramen transversarium. If we see on the lateral aspect towards the transverse process, we have these foramen which are termed as foramen transversarium, and these are the characteristic of the cervical vertebra. The foramen transversarium of C1 to C6, it gives passage to the vertebral artery as well as the veins. The vertebral artery does not pass through the foramen transversarium of the C7. Now for the thoracic vertebra, a characteristic feature present in the thoracic vertebra is presence of the facets. If you see over here, the presence of the facets on the body, on the lateral aspect of the body, as well as the facets are present on the transverse process also. This is for the articulation with the ribs, and it is a characteristic feature of the thoracic vertebra. Now in both of these vertebrae, if we compare the superior articular facets, in both of them the superior articular facets, they are directed backwards as well as upwards. So we cannot use the superior articular facets to compare these two vertebrae. So therefore when we go to this question, the answer for this question is C, because this is present in both the vertebrae and we cannot use this criteria to differentiate it. The typical cervical vertebra, it is having a triangular vertebral canal, it has a foramen transversarium as well as it has the small vertebral body. For the next question, for the abduction of thigh, it is limited by, when we are abducting the thigh, it will be because the abduction action will be caused by the abductors, so therefore that means it will be limited by the adductor muscles of the thigh. In this, if you see the option, adductors are mentioned in all the options. Now we have to decide in the ligament. For the hip joint, we are having three ligaments. The three ligaments are iliofemoral, the iliofemoral ligament of Bigelow, this is the iliofemoral ligament of Bigelow. Then we have the pubofemoral and istiofemoral. Now in this, if we see this picture, the pubofemoral ligament, they begin from the portion which is below the anterior inferior iliac spine. It begins from here and it goes towards the femur. It is a Y-shaped ligament which is present over here, and it prevents the hyperextension of the hip joint, and this is the strongest ligament of the body. The pubofemoral ligament, it is starting from the iliopubic eminence and going towards this, the portion between the greater and the lesser trochanter. It is going like this, and istiofemoral, it is beginning from ischial tuberosity, again going towards the greater trochanter. Now the ligament, pubofemoral ligament, this ligament is the one which is actually present towards the medial most side, and this is the one which will limit the abduction movement, because the pubofemoral ligament, it will pull the limb towards the medial side. So the answer for this question will be C. The abduction of the thigh is limited by tension in adductors as well as the pubofemoral ligament. The question number 16. The question number 16, it says that pes anserinus, it includes which of the three muscles? It includes all these three muscles except the B option, that is the semimembranosus. In this, if we see the pes anserinus, the word means, it is also termed as gyropes. It is also termed as gyropes. In this, if we see, the three muscles which are included in this are from the three compartments. The semitendinosus muscle, that is from the posterior most compartment, gracilis muscle from the medial most compartment, and sartorius muscle from the anterior most compartment. All these three muscles, the semitendinosus, sartorius and the gracilis, they are coming from the three compartments, and all the three muscles, they are attached to the tibia, and specifically they are attached to the upper part of medial surface of tibia. and near its attachment there is a anserine bursa which is present over there, which separates the all these three tendons from each other, as well as from the attachment point tibia also. So if you see in the limb, this is the lower limb and the knee over here, the tibia which is present in the lowermost portion in the leg, this is the tibia. The muscles are coming from different aspects. The sartorius muscle, it is coming like this and it is attached to the medial surface in the upper part of the tibia. The gracilis is coming like this, and from the posterior aspect we are having semitendinosus, which also comes like this. So that is why, due to the different directions of these three muscles, it is also termed as guy ropes, which are used to keep a tent in the pulled position. For example, when we talk about a tent, it is pulled like this in the different directions, and due to this it gets a name. In this, the common point is this one, and it is coming from three different directions. So that is why termed as guy ropes also. Now the question number 17, it says, in this, first of all we will identify the structures which are present in this picture. This structure which is present over here, this is the trigeminal ganglia, also known as Gasserian ganglia. The trigeminal nerve, as it takes origin from the pons, it is having a very short course, and then it goes and it is going towards the trigeminal ganglia. Now in the trigeminal ganglia, it is a bean shaped structure. The concave portion over here, there is attachment of the trigeminal nerve. This is the fifth cranial nerve, and towards the convex portion we are having three divisions of the trigeminal nerve, that is the ophthalmic, maxillary and the mandibular. So first one over here, this is the V1, which is the ophthalmic. This is the ophthalmic nerve. Then V2 is maxillary, and this third portion is the mandibular nerve. Now if you identify in this picture, this is the first division, this one is the second division, and this one is the third division. Now this cut section below, the bone is the temporal bone. This is the temporal bone, and within the temporal bone we are having the ear. The inner ear and the middle ear, they are present in the temporal bone, and the portion of the ear which is seen over here, we can see the various ossicles which are present over here, and the nerve which enters in towards the ear is, one of the nerve is the eighth cranial nerve, and the other is the seventh nerve, which is a facial nerve. So this nerve which has been shown over here, which is going like this, this is the facial nerve, and this facial nerve in its course, it is giving the various branches. The three branches of the facial nerve which are given in this course is, first branch is the greater petrosal nerve, then nerve to stapedius, and the chorda tympani nerve. This is the facial nerve, as we have discussed. This portion of the facial nerve is the geniculate ganglia, and the branch which is arising from here, this branch which is going like this branch is a greater petrosal nerve. So if you see, this branch is going like this, and this greater petrosal nerve, it joins with the deep petrosal nerve to form the median nerve or the nerve to pterygoid canal, and it will finally reach over here towards the sphenopalatine or the pterygopalatine ganglion. So the nerve which is being labeled over here, that is this A is the greater petrosal nerve, and it is going towards the ganglion which is labeled as D. This is the pterygopalatine ganglion. The pterygopalatine or the sphenopalatine ganglion. Now another nerve or branch which is given is, if you see over here, this branch which is going like this is nerve to stapedius, and this third branch over here, this is the chorda tympani nerve. It is going like this, then it exits out over here. So the B option over here which is marked on this nerve is the chorda tympani nerve. So now we know the various structures which are present over here. In this we have already said that the greater petrosal nerve, it goes towards the pterygopalatine ganglion, and this pterygopalatine ganglion, it will further go and it will send parasympathetic or secretomotor fibers to the lacrimal gland. When we talk about the chorda tympani branch which is going forwards, this chorda tympani, it will meet the lingual nerve, and then the lingual nerve will be further going towards the submandibular ganglion to send secretomotor supply to the submandibular and the sublingual glands. So this is further going to supply the submandibular and the sublingual gland. Now we come back to the question. In this it says that we have to choose the mismatch. The option A is secretomotor to lacrimal gland, A is the greater petrosal nerve, and yes, it is going to the pterygopalatine ganglion and it is secretomotor to lacrimal gland. Option B, it is secretomotor to parotid, which is wrong. For the parotid gland, we have the otic ganglion, and to the otic ganglion, the secretomotor fibers, they are being carried by the glossopharyngeal nerve. The C option is Gasserine ganglion. Yes, this is correct. We have already marked over here the trigeminal ganglion which is present over here. So this is correct. D is a sphenopalatine. That also we have labeled. So D is the sphenopalatine ganglion or the pterygopalatine. So the answer for this question number 17 is B. The answer is B. The question number 18, it says that all of the following are composite muscles except. Now when we talk about the composite muscles, also known as hybrid muscles, these are the muscles which are having dual nerve supply, and if we see in this, the answer for this question is A, because this is the only muscle over here which is having a supply by a single nerve, that is ulnar nerve. If we talk about the rest of the muscles, if we talk about subscapularis, it is being supplied by two nerves, that is upper and lower subscapular nerves. Then for the flexor pollicis brevis, the superficial head is supplied by a different nerve and the deep head is supplied by different nerve. The superficial head is supplied by median nerve and the deep head is supplied by ulnar nerve. So therefore this muscle is also having a dual nerve supply. For the biceps femoris, in this option, the biceps femoris, it is again having two heads, the long head and the short head. When we talk about the biceps femoris, the long head, it is supplied by tibial component of sciatic nerve. And the short head is being supplied by common peroneal component of the sciatic nerve. So we have peroneal component, common peroneal component of the sciatic nerve. So therefore the rest of the three muscles, they are having dual nerve supply except the flexor carpi ulnaris. Now the other muscles in the body which are considered as the composite muscles, we talk about these composite or the hybrid muscles. The other examples apart from this, one we have already said, subscapularis, then biceps femoris we have already mentioned, and the third we have mentioned, the flexor pollicis brevis. Now the rest of the muscles, one more muscle is there, pectoralis major muscle. The pectoralis major muscle, it is being supplied by medial and the lateral pectoral nerves. So pectoralis major muscle, subscapularis. It also includes the brachialis muscle as well as the flexor digitorum profundus. The brachialis muscle, when we talk about the brachialis muscle, it is supplied by the musculocutaneous nerve. Apart from this, The radial nerve is the one which is giving the proprioceptive fibers. For the flexor digitorum profundus, the flexor digitorum, the lateral half is supplied by median nerve and the medial half is supplied by the ulnar nerve. So it is also having a dual nerve supply. Then we have digastric muscle. The digastric muscle is having anterior belly and the posterior belly. The anterior belly is supplied by mandibular nerve and the posterior belly is supplied by the facial nerve. Apart from this, pectineus, the pectineus muscle is there and the adductor magnus also. When we talk about the pectineus muscle, it is being supplied by both femoral nerve and the obturator nerve. For the adductor magnus mainly it is supplied by the obturator nerve and its ischial head, which is arising from the ischial tuberosity, that head is derived from the sciatic nerve. So the adductor magnus, it gets supplied from obturator as well as the sciatic nerve. So all these muscles, these are considered as the hybrid muscles or the composite muscles. Question number 19, it says the nerve supplying the pharyngeal arches, they develop from. Now when we talk about the pharyngeal arches, it is having two components. The pharyngeal arch is being formed by the mesoderm, that is mesenchyme, as well as it is formed by the neural crest cell. Now these are the two structures which are forming the main component, which are forming the composition of the pharyngeal arch, and these two structures will be giving rise to the different components of the pharyngeal arch. This mesenchyme, this is derived from, the paraaxial as well as the lateral plate mesoderm. And the neural crest cells, they are derived from the neuroectoderm. Now the mesenchyme over here, it is mainly giving rise to the muscles which are being derived from this arch, and the neural crest cell, it is giving rise to the connective tissue. The neural crest cell which is present in the pharyngeal arch is the one which is giving rise to the bones, ligaments as well as to the nerves over here. So the answer for this question, for the question number 19 is B, that is a neural crest. The neural crest is the one which is giving rise to the nerves for each of the pharyngeal arches. The question number 20 is we have to identify this structure, this slide. This slide is a typical slide of the pancreas. The answer is pancreas. In this, if we see the slide, the whole slide is having these acini. The acini are serous acini which are present over here. And towards this side, this is a pale staining area which is present over here, and this is the islet of Langerhans. Now if we talk about these portions, the serous acini, they are typical, the acini, they are having a typical shape in which the cells are pyramidal shaped cells. The pyramidal shaped cells are there, and towards the base they are having a round nucleus. Towards the apical portion, it has granules which are termed as the zymogen granules. So it is having pyramidal cells with a nucleus at the base, as well as the granules are there. Due to the presence of these granules, it takes up more of the pink stain or acidophilic. Now in the serous acinus, a cell which is typical for this pancreas is the presence of centroacinous cell. The centroacinous cell, these are the cells which are seen in the center of the lumen of this serous acini. For example, we can see over here, this is the centroacinous cell. This centroacinous cell is due to the invagination of the intercalated duct. So if this is the acini, the intercalated duct, it is like this, and if we take a cut section over here, in such kind of section, the cells which are seen in the center of the acinus, those are the cells of the intercalated duct, and we use a term centroacinous cells for them. Now among these serous acini, in between the serous acini, we will be having the cut sections of the duct. The duct is the intercalated duct. Apart from this, we can have bigger sections of the duct which are interlobular ducts. Now this pale staining area, this is the islet of Langerhans. This is the endocrine portion of the pancreas, and it is maximally seen in the tail of pancreas, maximum in tail. And within this Langerhans cells, we have typically three type of cells: the alpha cells, beta cells, and the delta cells, in which the beta cells are the one which are most prominent, or they are 80%. 80% of the cells are the beta cells, and they are having granules, they are granular, and they will be secreting insulin. 20% cells are the alpha cells which are secreting the glucagon, and the rest of the cells, or the some cells, are delta cells which will be forming the somatostatin. Among this the beta cells, these beta cells over here, the beta cells are the one which are forming the majority of the population, and these are the cells which are present towards the center of the islets. The rest of the cells, alpha cells and the delta cells, they are present towards the periphery. So this completes the discussion of the first 20 questions. The next 20 questions will be in the next part. So thank you to all of you for the cooperation.